This is Connected Care Live, conversations with innovators and wellness professionals from all across the continuum of care. This series is supported by Solutionize, leaders in healthcare IT. You can find our entire archive of conversations on a range of topics in healthcare at www.solutionize.com. We'd love to hear from you. Hello, I'm Steve Cohen, host of CCL, and my guest today is Brandon George, the Executive Director of the Indiana Addiction Issues Coalition. Brandon sits on the advisory board for Indiana's Division of Mental Health and Addiction, is on the expert panel for the Indiana University School of Medicine's Project ECHO, and has presented to both state and federal leadership. Brandon is himself a person in long-term recovery from substance use disorder and is a thought leader on recovery support services, stigma reduction, and recovery-oriented systems of care. Brandon, welcome to Connected Care Live.
Thanks for having me, Steve. I appreciate it.
So nowadays, we tend to view addiction as an illness. We talk about the opioid crisis as an epidemic, just as we would refer to major influenza outbreak. But that hasn't always been the case, right?
No, there's quite the opposite, actually. For decades and decades and decades, we've really treated all substance use disorders, alcohol use disorders, as a moral failing. And even though it's been recognized for some time as a disease, we very much, honestly, the main means of treatment has been the criminal justice system. So we really saw that in the 80s with the crack epidemic and how the response was almost completely with force and with law enforcement and the criminal justice system versus the healthcare system. And I think that take a step back and look how we are starting to respond to this crisis compared to how we did in the 80s and 90s. You can see the stark differences in this more of a public health approach versus what we clearly saw as a public safety issue in the 80s and 90s. Some would also point out the differences in populations that are affected. So I think that we'd be remiss if we didn't at least mention the populations that are generally being affected by this, specifically with the opiates nowadays versus the crack cocaine in the 80s.
So we're talking about, a sort of racial, socioeconomic difference between the users of certain substances. Is that what you mean?
Absolutely. I just don't think there's any denying it right now. I mean, the response, we've got a lot of people dying right now, unfortunately. And the response has been, for the most part, very much of a public health one. When somebody's overdosed in a car, that person is taken to the hospital. And that is a very different response than it was in the 80s and 90s. And we can see that the crack epidemic definitely hit lower socioeconomic groups. You said mainly minority population communities. And I would like to think that we're treating it differently just because we've evolved as a society and because we have genuinely grown in our viewpoint. A lot of other people would definitely say, Brandon, you're being naive. We're treating this differently because middle-class white kids are dying. And if it were it wouldn't be responded to the same way if it were a different demographic.
Right. So it's interesting in both cases, though, there's an element, even now, where the disease or aspects of the disease are criminalized. Having the disease is not a crime, but many of the activities related to the symptoms of the disease are. So how do we deal with a disease that has been criminalized in this way?
I think that's the million-dollar question, right? So one of the most difficult intersection that we deal with substance use disorders as a whole is this crossroads between public health and criminal justice. And we have got, unfortunately, as long as there is this massive overlap or intersection, we're going to have people from the criminal justice system making healthcare decisions, and that is not what their expertise is in. Judges, I believe, have the most difficult position in this entire, when you look all the way across the spectrum of different people involved, different organizations, societal functions, judges have to try to separate what you're talking about. You know, is this a criminal is this a criminal that has bad intent, that wants to harm society, that happens to have an addiction issue? Or is this a sick person that has a disease that was just participating in a certain behavior to help overcome a craving that he has? And I believe that there can be some separation there, but there also has to be some accountability. What I would like to see is that, you know, if somebody steals a car, they have to be accountable for that car, but the criminalization around just using things or simply ingesting things into your body, paraphernalia charges, things like that, that are just directly related to using and not related to harming society. It would be really nice if we could pull that out of the criminal justice system. And if we found somebody in their car that had a needle and some heroin on them, that we got that person to treatment, not to jail. You know, if they hurt somebody or if they drive under the influence, then that's a criminal act. You've got to pay consequences. That person's a danger. So it's very, very nuanced, but we've got to make a shift in this and get it more into the health setting and less into the criminal justice. I don't know that we'll ever have complete separation, though.
Well, so that's interesting. So you bring up the idea that the criminal justice system is being forced to make healthcare decisions. So in some ways, we as a society are dealing with this healthcare issue in a sort of para-healthcare industry. It's not in the traditional healthcare system. And you mentioned treatment, and sometimes within the criminal justice system is referred to as diversion programs and that sort of thing. So insofar as it's healthcare, you know, what are the systems we're using, and where do those connect to the traditional healthcare system, or do they, or should they?
So unfortunately, a long time ago, and actually not too long ago, but when there started to be some treatment for addiction and it was classified as a health issue, even though it was classified, it wasn't really in primary health care. So you would have addiction-specific facilities that treated addiction, but it was completely siloed off from primary care physicians or the general healthcare system. And I think that's one of the biggest hurdles that we face today is, okay, we clearly misstepped decades ago by keeping addiction treatment separated. And how do we really integrate this back in? Because now we've got a workforce of physicians, nurses, providers that aren't educated in addiction. It's not taught in the same way that other illnesses are taught in medical school. I don't want to misspeak, but I think that there was a study done by a major university just a year ago that said that the average physician gets 1.5 hours of addictions training during med school.
Wow. 1.5
hours of addictions training. And that's just obviously, you take any other illness, and I'm guessing, especially when they're killing 72,000 people a year, and doctors are going to get more, but that's how we set it up. So I think there are changes being made, but when you step back and look, I mean, we're talking a decade before that catches up. You know, the people that are just now going into schooling, there may be some changes, but we're not going to see that for some time.
Now, I've heard you say that recovery has been synonymous with treatment, but your feeling is there's much more to that, right?
Absolutely. So this is another part of this concept of addiction as a disease. We give it the lip service. Providers say addiction is a chronic disease. It's written in literature now. But as we're talking about healthcare systems and addiction, our systems are very much set up as this is an acute care issue. Other chronic diseases, hypertension, diabetes, congestive heart, all these are going to be treated over a long period of time, years and years and years. Even a cancer patient that's in remission is probably going to be within the healthcare system for at least 5 years. But addiction, even though we say it's a chronic disease, we've got systems, payer systems set up in which the treatment is 30 days, 60 days, 90 days, 6 months. Even if it's 6 months, that's woefully unacceptable by chronic disease models. You know, could you imagine if you had diabetes or hypertension, going and seeing a doctor, getting insulin for 6 months, and then say, okay, you're good to go, you should be fine now? It would be unheard of. It would be malpractice, actually, is what it would be. And so this idea of the ongoing recovery process and being healthy and being plugged in, I almost think of treatment as the acute intervention, almost like a surgery, if you will. But after that surgery, somebody needs physical therapy. And the recovery process is kind of like the physical therapy process. The ongoing process in which somebody's going to maintain their health. You know, a diabetic maybe that was overweight, while they may take insulin for their blood sugar, they also would need to diet, they would need to exercise, and that's what their recovery process would look like. And when it comes to substance use disorders, there is a recovery process as well, and we need to make sure systems-wise that we set people up for success and that they have access to recovery support services, recovery coaching, recovery residences as part of their continuum of care.
So I'm glad you brought that up. What are some of the barriers right now? And you know, we often here at CCL, we get into the issues of HIPAA and how that sometimes makes it very difficult for the people involved in a chronic condition, in a patient with a chronic condition, getting all the care they need with all the different participants in that care, in the continuum of care. But it's even harder in substance abuse disorder, right? I mean, there's even more barriers than HIPAA.
There is, and this is, so running an addictions advocacy group, I would consider us taking a little bit more progressive stance on what you're talking about. 42 CFR Part 2 is some patient protection added on specifically for those with substance use disorders that put additional, what they called protections in place to help protect patient information, and it served a really, really great purpose for a long time. The stigma around addiction is suffocating, and I say that today, and it's true, but beforehand, the stigma would dismantle your life. You would get fired from a job, you might get incarcerated. There was all these things that you could suffer if somebody found out you had substance use disorder. So when this was put in place, it was really vital to protect people. But now, as we start trying to integrate addiction medicine and addiction care into primary health, we've got this barrier in place. We've got this, you know, look, we've already got HIPAA in place to protect patient privacy. And I don't think that we are going to be able to fully integrate treatment for addiction and substance use disorders as long as 42 CFR Part 2 is in place. It prevents the free communication between providers. And I certainly don't say this lightly. I recognize that it would get rid of some protections. However, we can't deliver the best care possible with this in place. And some of the newer systems that are being put in place, a group called Facing Addiction is putting together a new payment model. They've been working with Anthem and the American Hospital Association to come up with a new payer system that's more effective. It's better for the person receiving care. It's better for the payer. They feel like they're getting we'll get better outcomes this way. But all that revolves around people waiving 42 CFR Part 2. And I think that's the way that any new system, like the way that we pay, the whole system around payment, around addictions and treatment is completely broken. And this is going to be part of moving that forward. I mean, you need people communicating around this patient, just like another chronic disease. If you had a geriatric patient or somebody that had a chronic condition and they had caretakers, you would need free-flowing information from all parties. And there are new systems coming into place. There's a program called Team Patient that allows, it's used for chronic condition, and it allows the person who's getting care to have all their caregivers, providers, essentially communicate freely with each other. And they get to circle around this person in need and really circle with them with all the services and all the support they need. But that's not possible without that person waiving that protection there and allowing that information to flow freely.
And do you think that the social aspects of substance abuse disorder play a bigger part, making that communication and the coordination more important than it would be in, say, like you use the analogy of a diabetic? Ideally you'd have their family not bringing home cake every day, just making it harder on the person. There must be even more of that in the life of someone dealing with addiction.
Absolutely, and so especially given the way that people are overdosing now. It used to be if an alcoholic went back out and drank, yes, they might ruffle some feathers. Yes, they might feel terrible the next day, but most likely they weren't going to die. And so like you're talking about now, having communication between family members, between recovery coaches, between counselors, between maybe support groups, like your 12-step recoveries and your Celebrate recoveries that can all help provide information to each other about what's going on, all in an effort to keep the patient healthy. And what normally happens is, speaking as somebody that's in recovery, is I tried to separate everybody. So I would keep my family away from my counselor, which I would keep away from any other party, and that way I could kind of continue what I was doing and continue to feed my addiction as it was, the cravings were just overwhelming and had me separate all these people out. And if we could, when somebody relapses, if we could identify that within a day or two versus a couple of weeks, it changes the whole dynamic. And the way that it's set up right now, information-wise, it takes weeks to put puzzles together. And with ideas, new innovative ideas like the one I was just talking about with Team Patient, allows people to say, hey, John came in at 2 a.m. last night. He didn't look very good. He was pretty short with me. And then somebody else being able to acknowledge, well, he didn't come in for his Vivitrol shot last week. So maybe we need to take a look at this. And you can coordinate that much, much faster versus finding out a month later he didn't come in for his medication.
That's I could see how that would be a powerful tool to accelerate the ability to catch things before they spin out of control.
That's the key, spin out of control. When you can get it before the train completely goes off the tracks, the odds of getting that person back into the recovery process are much, much greater than once that train has picked up a full head of steam. And it gets to a point where you just got to let it into crashing, so to speak, and you don't have an opportunity to get it back on the track.
So you mentioned Vivitrol, and what's the data around medication? Are we seeing useful pharmaceuticals come into play?
We definitely are. And so this seems to be a hot topic in the treatment of addiction. You've almost got two separate camps here, one of what we would call abstinence-based and one that is not abstinence-based, which is the use of medication. And as a healthcare issue, that seems kind of absurd. We don't have two camps when it comes to diabetes, right? We don't have the camp that goes to take insulin for it and the other camp that just tries to diet and exercise a whole bunch, which could be helpful, but it also could not be helpful at all. And we just have two different belief systems. Of course not. That's absurd. And the groups out there that believe what they believe in these two areas are pretty far apart. And I think the stigma around medication really prevents us from using it in the way that we should. Data, there's overwhelming data that medication for opioid use disorder saves lives. I think actually there was about 40 years of data on methadone, says that it decreases mortality by 53 to 73%.
There's a lot of stuff that physicians will prescribe that doesn't have nearly
the effect.
Right.
Efficacy of that. So correct. And so
right. So why the stigma? Why is there a stigma around using medication here in this context?
When I talk to people, I ask them, I said, look, if there's any other illness, 2,000 people dying a year, and we had a town hall session, and I said, great news, everybody. You're not going to believe this. I have got a medication that's going to save at least half the people in the room, and most likely 3 out of 4 people now are going to live. When we got done with that meeting, people would be in line to come up and talk and to, how do I access this medication? Please, I want to save my son. I want to save this, my family member. But with this, we shame people for it, for taking a medication. And you touched on it, that stigma word. The idea that we stigmatize people for using a medication is just, it's hard for me to wrap my head around now that I know the data and I see the lives that are impacted. There's somehow this hang up that the medication or the substance is the problem. It's not. With addiction and substance use disorder, it's not the substance is the problem. It's a brain disease. It's a mental health disease. It's not the substance that's actually the issue. It's the thinking. It's the change in your brain activity and your brain pathways that's the problem, not the dependence on the substance necessarily. And people confuse dependence for addiction. And those are two very different things. All of your SSRIs, your antidepressants, and your anxiety medications, they cause dependence. If you stop taking them abruptly, there's a warning label on the back that says may cause homicidal or suicidal ideations. That is an extreme consequence of dependence, right? Like the idea that you might have homicidal thoughts. Well, these medications have a dependence too. They're a physical dependence. If you stop taking them, you may get the shakes. You may have cramping. You may experience these physical symptoms. But that addiction is represented in the DSM-5 by categories. How are your interpersonal relationships? How's your ability to hold a job? Do you have problems with law enforcement? And those are the symptoms we should be looking for reduction, not whether or not somebody's actually taking a medication.
So does this relate back to, does this stigma relate back to the idea that there are good drugs and bad drugs, right? And also to the abstinence, from a different context, the abstinence only model, right? That's birth control, but there's the abstinence versus non-abstinence, and good drugs and bad drugs. Opioids are an interesting one, right? In that they began their life as a medication, but now are seen as being something similar to let's say, cocaine, which has no current medicinal use. So is that where this is all coming from? This sort of built-in hypocrisy?
Yeah, a lot of it is born out of how society has chosen to place some drugs in a, quote, good category and some drugs, quote, in a bad category. Talk about the 2017 data just came back on overdoses, and it was 72,000 people died. In 2016, there were 65,000 people that died, 40,000 specifically from opioid overdose. So that's your bad drug, your quote bad drug. Your the things that are being used illicitly killed that many people. Alcohol, what we would consider our quote good drug, killed 88,000 people the same year. So alcohol killed twice as many people as opioids did. And further that, you could talk about nicotine and tobacco, which played a role in 480,000 deaths that same year. So our quote good drugs killed 560,000 people, whereas we're talking 40, 50, 60,000, 65 total for all quote unquote bad drugs. But because of the stigma, we don't give the others nearly the same attention. We're certainly not changing policy and laws around alcohol and tobacco right now at the same rate that we're changing them around opioids. And I do think, the societal views and the stigma around it really has, when people want to quit smoking, do we shame people for using the patch? I mean, that's the most direct line with medication right there. People say how can you give somebody an opiate to treat an opiate problem? Well, we do it with tobacco. It's exactly how we usually get people off.
Yep.
Gum, patches, and we wean people off. And sometimes I've got a friend that's been chewing those nicotine gums for 10, 15 years. Are you telling me he's not better now just chewing that gum than he was smoking? Of course he's better now. The risks of that gum are minimal compared to the continued smoking over 15 years. And I would argue the same about opioid use or heroin use. Somebody taking a medication for however long they need to, the risks associated with dependence pale in comparison to the risks associated with somebody who's an IV drug user, who has to worry about Hep C, HIV, all the other things that come with using that way. So it's amazing how society can kind of paint our views for us and our responses to those.
So to end on a hopeful note, you were talking about some of the systems, some of the programs. Are there any other recent legislative changes that can help bring addiction treatment and recovery and that sort of continuum of care to make it more likely to reach the people it needs to reach, even while we're dealing with these societal attitudes?
Yeah, look, there is as many problems as we face, and it's my job as an advocacy group to make sure that I'm advocating for changes in these areas that we still need it. Let's not overlook the wins that we've had, and some of those wins there is a greater acceptance of medication, specifically around the medical community. Doctors, people that look at data on a regular basis, like you were talking about efficacy of medications and what the best approach is to baseline, keep somebody alive, and then improve their quality of life, are starting to pretty much widely accept that when somebody has alcohol use disorder, opioid use disorder, that we've got that those should be kind of the quote unquote easy ones. We have a medication that helps with this. Your other ones don't have medications, and so a greater acceptance around really embracing a medical model, a willingness by physicians and primary care doctors to say, hey, I want to play a role in this. I see my patient's family struggling with this, and I'm tired of just saying, hey, you need to go to the local detox. Like, I want to play a role in this, and that's happening across the country. I think that's a great step in the right direction. The building of recovery supports, that ongoing process. A lot of legislation right now is including communities must include recovery support services in their systems, in their communities, so that people have the ongoing care to where it really is treated like a chronic condition instead of that acute care. Recently, we've had legislation passed, $6 billion dedicated over the next 2 years, $3 billion a year, 900+ million going directly to states. I know Indiana's portion specifically was a little bit over 18 million, but that wasn't it. Those grants were in August and should be actually dispersed in October. And then just at the beginning of this week, actually, what great timing, another opioid package was passed in the Senate and is waiting for reconciliation now. That is going to include another $500 million a year for the next several years to help bridge the gap in some of this. So we're getting massive resources that we've never ever seen before, and it's up to each community to help build the infrastructure. We've got a workforce shortage that needs addressed, but there is gratefully a lot of attention being paid to this right now, and we've got resources that we haven't had before to put the proper responses in place. So as much as work we got to do, I've got a lot of hope that we're heading in the right direction.
Well, Brandon, thank you so much for the work you do, and thank you for being a part of Connected Care Live.
I appreciate it, Steve. Anytime. Thank you.
To get more insights and information from healthcare innovators and pioneers, go to www.solutionize.com.